Thank you very much indeed. I have no perceived financial or other conflict of interest. I haven't taken inhaled steroids, though one of my sons has. I was rather curious that Paul was assessing the effect of his inhaled steroids by apparently auscultating his heart, but then he is a Dutchman. So the aims, I'm going to show the Commission's starting position. This is based on the Lancet Commission and why we believe that a new approach was needed. Briefly summarise the 7 recommendations, which have the premise that asthma as a term in isolation is no longer useful. I'm going to focus on personalised medicine, long forgotten. One of the depressing things is when you think you've had a good idea, you go back and find that somebody's had it a long time ago. And I'm going to propose that asthma guidelines are not merely useless, but positively harmful. hopefully to keep you guys awake. And I will discuss the futile E word, exacerbation, which again I think should be banned. So I hope that will be sufficiently provocative to keep you going. Basically, that is what I propose to do. You remember Humpty Dumpty? I went and shouted in his ear. Well, that's what I'm proposing to do, and I hope I won't fall off this podium. So this was the Commission. We talked about wanting to revolutionise airway disease and deliver precision medicine. Move beyond asthma control. I wanted to say palliative care. Giving steroids, as Paul has highlighted, is great, but it's palliative care. It suppresses the symptoms. It does not cure the disease. Emerge from our age and discipline associated silos. Test before treatment, a measurement culture. Zero tolerance of asthma attacks. Maximise treatment opportunities in severe disease and better research. And of course, I'm not going to attempt to cover all of this in a short talk. So, personalised medicine. And we've had 60 years of amnesia about personalised medicine. So, once upon a time, as all the best stories in paediatrics start, the MRC trials said that prednisone did not work in asthma. Now that's a bit funny. How many people here have given prednisolone for acute asthma in children of any age? Probably virtually everybody. And they do it because they think it works. So this is Harry Morrow Brown, a really great man who was a consultant chest physician in Derby. And he thought this was a bit strange. So in the days when we had microscopes as medical students, he took his medical student microscope and started to look at sputum. And he looked at sputum and he saw 2 things. Some of the sputum was full of neutrophils, some were full of eosinophils, and the neutrophilic one didn't work, but prednisolone did work in those who had eosinophils in their sputum. And without that study, probably prednisolone, one of the most effective life-saving medicines we have, would have probably been discarded. And this is beclomethasone, and he came along and showed exactly the same thing with inhaled steroids. You need to have eosinophils in your sputum if you're going to respond to inhaled steroids. And we got so excited about the benefits, which are enormous, of inhaled steroids, and the lack of risks of low dose, which is also true, as Paul has summarised, that we actually forgot this personalised medicine. And we made the same mistake, nearly lost mepolizumab for doing it in the wrong patients. So, one of the things, have we made any progress in the last 25 years? And I owe this quotation from Mark Rosenthal. We've talked about asthma, but we've not progressed beyond a blue and a brown inhaler, measuring the urinary cotinine and looking menacingly at the PET cat. This is what asthma was like when I was a medical student 40 odd years ago. This is what asthma treatment is like now. What new diagnostic and monitoring tests do we have? We may have a bit of a browner inhaler or a bit of a more long-acting blue inhaler, but conceptually, where are we? And we've often, I suspect, stalled asthma research because we failed to ask which asthma am I researching. Why asthma still kills, the National Review of Asthma Deaths. Outcomes have stalled, and anybody who has read this will think, why are we still losing children from asthma? And this is the gay mortality. This is Richard Beasley's work. You can see here where steroids really take off, and the outcomes have improved, but over the last decade, it's very difficult to argue that actually we're making progress. This clicker seems to have died. I'll hide behind the screen before I get too provocative. Sorry, maybe it's me having a bad effect on this, but I can't get the slide to change. Here we go. Right, so getting a measurement culture in the bloodstream, and I talked a little bit about this on the first day. I'm not going to give Jimmy's talk, and I must be allowed 3 slides on asthma diagnosis. This is a great Dutch study, and I admire the chutzpah of the Dutch doctors who published this. 4 academic primary care centres in the Netherlands. So this is likely to be pretty hot stuff internationally for primary care. And they looked at those who were coded with asthma, and they found 546, and 106 were uncoded but provided asthma medications, and over 300 of those coded with asthma were not using asthma medications, which doesn't inspire confidence so far. Only 1/5 had any objective evidence of an asthma diagnosis. And this is the number, and they reckoned at least half of their patients were overdiagnosed. As I say, this is good primary care. And overdiagnosis, it matters. You might say, okay, just put steroids in the tap water, they're quite safe, as Paul has pointed out. But actually, over-treatment and trivialising the diagnosis matters, because you don't focus on the ones that really need focus. Very few had an objective diagnosis. If this is academic primary care, God knows what it's like in any other setting. And I'd like to challenge you, can you name a single other illness where there are, for children or adults, where there are simple investigations that can be done and they're committed to treatment with no objective treatment measurements when such can be performed? Is there any such situation in the whole of medicine that we've allowed ourselves to get into here? Just again, this is a Norwegian study to broaden again, measure. The questionnaire study looking for symptoms of exercise-induced bronchoconstriction and exercise-induced laryngeal obstruction. And a subsample underwent standard treadmill tests for both these conditions. And you can see more than half of those complaining of breathlessness had neither of these conditions. Many of them had been treated with asthma medication, and they were not particularly the obese in this case, but they were deconditioned. And measure. This was a great paper, I thought. And the fact is, whatever the benefits of inhaled steroids, they are not good treatments for being an idle slob. They really are not. If they were, I would take them myself. So, asthma versus the asthmas, deconstructing the airway. What do I think we should do? So what is this thing called asthma? Is it airway inflammation? Is it variable airflow obstruction? Is it bronchial hyperresponsiveness? A doctor said so. I was once given an inhaler. You'll find all these in the literature. The GWASs, a fantastic sophistication of genetics. And what's the current phenotype? Doctor diagnosed asthma. Well, I've shown it's probably 50, a good chance, an even chance it's wrong, even in good doctors. I want to know who the doctor is. What is it? And the suggestion, as Gary has said, is that that it's an umbrella term and that we should just use it as a clinical descriptor, nothing else. It means wheeze, breathlessness, chest tightness, plus or minus cough, and it is the start of a diagnostic journey, not the end of it. Just as anemia, low hemoglobin, that is the start of a journey. If you went to your GPs and he said, you're anemic, and that's your diagnosis, or you're anemic, I'm going to give you iron without any other tests, you'd think they were crazy. Same for arthritis, hot, red, painful joints. We need to be using asthma just to describe a clinical syndrome. And again, this is an idea that came from the great in the past. Look at what's going on in the airway disease. What are the components of the airway disease? Is there bronchoconstriction? Is there fixed and variable airflow obstruction? Variable airflow obstruction does not necessarily have to be bronchoconstriction. If you've lost these delicate alveolar guy ropes, you'll have airway instability. Is there airway inflammation? Is that present or not? What's the cell type? Is inflammation beneficial? What are the pathways? Is there airway infection? In adults, cough reflex sensitivity. All this, of course, was actually nothing to do with us, but the late, great Freddie Hargreave, who was doing this for years and years ago, actually saying what's in the airway, what's going on, and targeting treatment. And also, I shan't discuss this talk, What are their systemic comorbidities? What are the social and environmental factors? And we've heard about adherence, probably the single most important thing that we need to consider. So it's a clinical definition, it makes no assumptions, and you start a diagnostic journey attempting at all ages to look for physiological evidence of variable airflow obstruction. Are they atopic? Do they have airway inflammation? And there are numbers of tests that you don't need, they're not nuclear physics. You don't need to be to sophisticated apparatus. We can do these things. Yes, at the moment we do not have a biomarker for asthma. We should have a sort of a gene profile that should predict. We don't have that. But the more of these tests you do, and the more that are negative, the less likely is asthma a diagnosis. So how does this work? This is ivory tower stuff. And what about, this is a really great study from the USA, the infant study, 300 children aged 1 to 5 years in 18 sites. They had in a random three-way crossover, blinded, daily inhaled steroids, daily leukotriene receptor antagonists, and as needed inhaled steroids and short-acting beta agonist. And they used a composite outcome of asthma control days and time to attack requiring oral steroids. Their pre-specified analysis was to look at air allergen sensitization, gender, and attacks of wheeze, not bloody eosinophil count. That was a post hoc, and remember that. They had electronic diary monitoring during run-in, but I don't think electronic adherence. They had no placebo washout period, so they discarded the first 2 weeks of the data. And 40% of these were air allergen sensitized, and 60% had a positive modified asthma predictive index, which is a measure of your likelihood of getting asthma. And they had 270 who were analysable, and of whom 60 had no differential response to these treatments. So what did they find? That's their definition. It's a composite definition. Despite the enrolment history, they had to be severe. Many improved, and if you improved, not surprisingly, you didn't need treatment, so you didn't there wasn't a particular treatment difference. For the analysis, though, so these are the non-differential responders. They all did very well. Very few had an attack. But if you look here, the daily inhaled steroids were much more likely to actually get benefit than if you had intermittent inhaled steroids or if you had montelukast. And only air allergen sensitization predicted a differential steroid response. So if you were air allergen sensitized, you were likely to respond to inhaled steroids. They did a blood eosinophil analysis post hoc. And again, if you look here, if you had a raised blood eosinophil count, you were much more likely to respond to inhaled steroids. And a blood eosinophil count is not exactly rocket science. You can do it. You can do it on a finger prick for that matter. Post hoc again, they combined eosinophils and air allergen sensitization. And look what they showed. You're able to target with two simple things that anybody can do. Are they likely to respond to inhaled steroids? And I would put it to you that this is a better approach than just giving steroids to everybody. The LTRAs did worse in all analyses, and as I've shown, if you were air allergen sensitized and had a blood eosinophil count of more than 300 per microliter, you did well with steroids. And if you didn't, you didn't. And unsurprisingly, many got better. Paul talked about the need of titrating doses down. Of course, that's quite right, and that's the drawback for CAMP and other studies. You titrate down. Because, of course, if you've got mild disease, you don't need treatment. So how does this work in practice? There are numerous airway diseases, some of which I've listed. So let's look at BPD and preterm. Do they have asthma? Well, if you look in the literature, they have no evidence of airway inflammation. They don't have an elevated nitric oxide. They do have variable airflow obstruction and fixed airflow obstruction. And accordingly, you just treat with beta agonists. You don't use inhaled steroids. Numerous others. And the suggestion to you that actually defining what's going on in the airway and looking at your treatment and doing your treatment accordingly is the way forward. So asthma is a description, not a diagnosis. If you see a patient, do they have an airway disease in the first place? If yes, what's the phenotype? And what's the context in terms of extrapulmonary and social and environmental effects. Phenotype the airway and don't treat what isn't there. If they don't have eosinophilic airway inflammation, why are you giving drugs active against airway eosinophils? And the next step, of course, as we've discussed, is from phenotype to endotype, but that's the story of another day. So asthma guidelines, pernicious. So evidence-based guidelines, I'm sure we've all seen these wonderful evidence-based charts, and somebody needs to say for children, most of these charts, this is the naked emperor. He is absolutely stark naked and has no possibility of getting any clothes. So why am I making this outrageous statement? There are two key studies, both of which Fernando was heavily involved in. And this was a very important, good question. In children symptomatic on a good dose of inhaled steroids and long-acting beta agonists, should you add leukotriene receptor antagonists or should you add azithromycin? Great question. Great group doing the study. They assessed 292 for eligibility and could only randomise 55 of them, because most of them they were screened were either not taking their medicine or didn't have asthma. And I'm not saying this to poke fun at Fernando. This is a really important finding. In other words, you should be starting to ask, if they're not responding, what's going on? They don't need more medicine. And this is another really great study, the Badger study. 182 children symptomatic on relatively low dose fluticasone, and in random order they had their steroids jacked up enormously, or had salmeterol added or had montelukast added, and they looked at predictors of response, pheno, PC20 to methylcholine, beta receptor polymorphism, asthma control tests, salmeterol 1, and it's particularly in those who ACT was the best predictor. But the important thing of this study is very few children actually got any benefit from increasing their steroid dose above 100 micrograms twice daily of fluticasone. Very few indeed. So this is what our guidelines really are. I'm sure everybody recognises Christopher Robin and Winnie the Pooh. And he's going up, here he is going solemnly up the steps. That is the child who's being dragged up the steps, bump, bump, bump on the back of his head. His parents, I'm sure thinking, why, there must be a better way of doing it. And who's at the top? Why, Big Pharma. They're the ones that are benefiting, as we are giving more and more medicines where the trial data is that actually if they're not responding to low doses, there's something funny going on. And what I do for non-responsive asthma, I do not give more and more treatment. Do they have an airway disease at all? Is there a differential diagnosis or untreatable comorbidity? Are they taking their treatment? Probably not is the answer. What about their environment, the pet cats, the tobacco? Psychological factors. We do not go for more and more treatment, easy option though that is, and very agreeable though it is to Big Pharma. So finally, asthma attacks, lethal. And exacerbations is a word I think that should be banned by law. It sounds relatively benign and mild, like you've fallen over and torn your trousers, well you can get a new pair of trousers. In fact, lung attacks, which I think is what they should be called, are an emergency. In many settings cause irretrievable damage, and they need a focused response. Why did this happen, and how can we prevent it happening again? Because the biggest single predictor for asthma death is having had a bad asthma attack before. So lots of reasons for attacks. In preschool, in the non-atopic preschoolers, there may be pure viral wheeze attacks, particularly mainly in adults, but in some children, allergy-driven wheeze, the thunder attacks, thunderstorm and soybean asthma. But most of the school-age asthma attacks we see, there's a viral trigger on an atopic allergic background. So is it all hopeless, or can we do something about it? So this is Adnan Kustovich's work. He's already shown that the combination of allergen sensitization, allergen exposure, and viral infection was strongly predictive of an asthma attack. So the only thing you can change is exposure to the allergen. So they randomized children aged 3 to 17 years of age. They had to be admitted with an asthma attack to hospital. They had to be house dust mite sensitized, and they were randomized to either mite impermeable bedding covers or placebo. And it was a big study, 286 were mic sensitized, and virtually all of them were randomized. And what they found, there was a significant risk reduction of a further asthma attack. And here you can see the probability of being without an emergency hospital admission. This is the mite impermeable group. This is the placebo group. There is a substantial difference. There was unfortunately no difference in steroid use, but I think this is proof of concept that actually there are things we can do after an asthma attack, and we should kick on from here. And perhaps actually what they did was too focused. This is Wayne Morgan's study in the New England Journal of Medicine from nearly 15 years ago, where they did in a inner city area, a multiple attack on the environment. They did a home visit, they machine gunned a pet, they got them to put air filters, house dust mite, education, and they showed improvement over the year in days without symptoms, and this persisted for a further year. And I think this should encourage us, if we see a child who's had an asthma attack, this should be a never event, like chopping off the leg of the wrong leg in surgery. What's gone wrong? Was there a plan? Was it followed? This complacency of saying, oh, have 3 to 5 days prednisolone and don't bother to come back. What sort of treatment is that we don't even monitor the response? So attacks, despite the plethora of ever more evidence-based and longer guidelines, people are still dying of asthma. We don't need more guidelines, we need better to learn lessons. And Paul was very flattering about the BDS guidelines, and I contributed to them, but I have to say, by the time you've read them through from start to finish, your patient is either dead better or gone off to see somebody else. They should be a major sentinel red flag event. It's a sign of failure. Something has gone badly wrong, and this is not a trivial inconvenience with your standard 3-day course of prednisolone. Something's gone wrong. What are we going to do to stop it happening again? Because these are the children who are at risk of death. NRAD showed that. Everybody showed that. This should be a real wake-up call. They can and should be prevented, and if they're not being prevented, should prompt a major review. These children should be being seen. What went wrong? Were they taking their treatment? Answer, almost certainly not. We've got to do better than what we're doing. So in summary and conclusion, final thoughts. There is nothing whatever to commend the use of the term asthma other than as a description of symptoms and the start, not the finish, of a diagnostic journey. The use of this term could have cost us valuable treatments in the past by lumping all comers into studies and missing treatment effects. The use of asthma in its current means we waste time on facile questions rather than treating the treatable. So the facile, a 3-year-old, is it asthma, doctor? Well, the child is wheezing. Why is the child wheezing? What should I do about it? Rather than a facile question like, is it asthma? And the continued use of the higher steps, for which there is no evidence whatever, of so-called evidence-based guidelines, only benefits pharma. And asthma attacks should be a wake-up call, a never event which should prompt a really focused and detailed response to stop them happening again. Because if you don't do that, as sure as God made little apples, they will happen again, and some will end up dead. So thank you very much for listening.